Good afternoon, everybody. Since it is 1 o'clock on the dot, I think we're going to start and get ready here. I am Marie Hensley, the Health IT and Reimbursement Specialist here for Community Care Network of Kansas. Just a few notes before we get started. We are recording this session, and we'll send it to you in an email after we get done with the webinar. All of your microphones have been muted. You can use the chat or unmute to ask questions. And then at the end of the webinar, we will have a short survey. You will see that survey be put in the chat. We would love if you would fill that out. Let us know how we're doing and anything that you would want to see in the future. Our presenter today, Daniel Creitz, has served as the Senior Vice President and Chief Compliance Officer for the Community Health Center of Southeast Kansas for the past 8 years. As a member of SEK's leadership team, he is responsible for all legal, regulatory, and compliance matters. Prior to joining SEK, Daniel practiced business and tax law in Pittsburgh. He holds a Juris Doctorate from Washburn University School of Law and is a member of the Kansas Bar Association, the Oklahoma Bar Association, and the Bar of the Supreme Court of the United States. I'll hand it off to Daniel.
Hello, everyone. We're going to talk a little bit about some payer contracting and best practices today. Like I said, please put stuff in the chat. We're happy to talk about it as we go around about. But I'm gonna get started. Roadmap for today is I'm going to talk a little bit about the current Kansas landscape as it relates to contracting. And then I'm going to talk a little bit about insurance contracting, more about the how and the what. And then probably a good chunk of our time is going to be spent on contracting pitfalls and key things to look for when you're reviewing these contracts. There are many styles of insurance contracts, which we'll get into elements, but there are key provisions that are pretty uniform amongst all of them. So I'll walk you through some of the things I look for this on. I talk a little bit about the current Kansas landscape. Some of this we won't spend a lot of time on this. Some of this really, I believe, affects how insurance contracting is going to look in the future, and so it's important. You guys know for a large part that there's many rippling factors to reimbursement that get accounted for. The type of healthcare entity, the service rendered, mainly provider versus facility billing, provider versus facility-based enrollment. Given the ever-changing landscape relevant to telehealth, patient location is an ever important thing, really on the commercial contracting side. And then type of insurance. In my corner of the state, we're seeing an increased amount of MA-based contracts at a crazy clip, and so trying to pay attention to that as it relates to the reimbursement in our service area. Healthcare entities. I kind of like to talk about healthcare entities in Kansas because it helps affect the role of our centers and those that we collaborate with. You guys know these are the primarily 4 type of entities in the state, and of which we hold a lot of weight. So we're going to walk a little bit more through the federally qualified health center piece of this, and stay away from the rest. But I always when I was talking to actually some attorneys about insurance contracting a couple of weeks ago, I always like people to understand exactly where we are versus our collaborators in healthcare. And so I love this map that gets updated every year through the Rural Health Information Hub. It helps me better understand who we need to make sure we're collaborating with, especially with related to discharge information. And getting that information timely. And so I use this every day, but it is a good resource for me as I'm even thinking through contracting and looking through what the contracts look like. I always like to, when I talk to my staff, one of my departments is credentialing and contracting, and one of the primary elements I'm looking for when I look at definition-based contracts is I'm looking for safety net providers and how they define it within the base of those contracts. We'll talk a little bit more about what this means later on, but I also like to lead with this. Many commercial contracts use a definition of safety net provider versus FQHC now. And really, you know, when I like to pay attention to this because I want to make sure they have that first bullet in there. Are you maintaining that section 330 grant? And as it relates to some of the proposed changes, and how we would receive our funding federally if there's some solid, that, you know, formal consolidation, is there language in the contract that better illustrates that we don't have to rewrite the successor and interest on the Public Health Service Act side or the HHS side. So the safety net provider definition is getting a little bit broader, specifically with the movement of SAMHSA underneath the HHS areas of responsibility. I think that we'll see some changes in health insurance contracts, maybe see a better grouping of our contracts and mental health center or CCBHC contracts in the future. But that's something I certainly want to pay attention to as it relates to the reimbursement. Our sites are a little bit more rural, and so, but I'd like to also, again, I boiled this down versus our UDS data and pay attention to, again, where are our rural sites and who's seeing us and where. I'll kind of walk you through a couple scenarios here. Hospital closures, as you guys know, is an ever-present reality in healthcare. And so I think that certainly is going to affect how insurance contracts treat FQHCs, and how we will be able to leverage those contractual relationships when we might be one of the fewer games in town as it relates to providing services. So, like I said, that was going to be the kind of my quickest part of it. I want to talk about payer contracting now. I'm going to talk about the how and the what. Something I also want to mention is, as it relates to this side specifically, this gives you a pretty good breakdown of how I analyze contracts. I'm looking at straight Medicare and our value-based care MSSP contract. I'm looking at Medicaid, at least in 3 states. Our patient base comes from primarily Kansas, but with Oklahoma sites, and then we get seem to get an increasing amount from patients from Missouri. So I'm paying attention to Medicaid contracts in those 3 states. I'm comparing provisions on base Medicaid contracts versus MCO Medicaid contracts, and also looking at any form of state plan amendment language related to that. Commercial contracts is kind of an ever changing market in my opinion, but it's a bigger piece of the market. It seems like we seem to be getting more commercial patients across the board, but primarily in dentistry. In our area of the state, we're seeing a lot less dentists. More dentists are retiring, and no one's coming in their place. So we're seeing more dental patients that have an assortment of payer responsibilities, and so really paying attention to how we're getting reimbursed in the dental world and how our dental contracts work on the commercial side. Marketplace, as you guys all know, is changing drastically with the eligibility provisions and deductible issues. TRICARE, it's pretty standard along with the VA community care plans, and then telehealth I'm really paying attention to BH, and addiction treatment in that world. And also looking at a lot of originating versus distant site, language, uh, as it relates to commercial contracts in telehealth. The originating and distant sites both need to be, associated with our 10 and be a patient's home. Where does that need to occur? Uh, as it relates to almost all of these, I'm also looking at outreach, seeing if there's any areas of concern there. And then I'm also paying attention to our residency program and seeing if we have any work there. So I say this to say it gives a good illustration. It's 7 buckets, but it's a good 7 buckets. It helps keep things in the front of my mind. You guys must know most of this know this, but we have 2 levels of enrollment. You have entity and facility-based enrollment, provider enrollment. I think a lot of times that there is a bigger issue of facility and entity-based enrollment versus provider. I'll walk through that here in a minute, but I think the consistency, if there's anything amongst the payers, entity enrollment. Most entity enrollments, the fact is that they're universal across the board. So that's that second bullet. The base contracts and the professional enrollments, require them to be tied together. You can't have one without the other. And really, if you're adding a service line, I'm saying in most commercial contracts, between 90 and 120 days. So need to be understand, you're adding a service to an existing facility or you're adding a new facility, and what that looks like in health center. Enrollment, I think your enrollment really determines a lot of things and how you process it, whether you do it quickly. It just really leads to a lot of your issues. I think the commercial contracts, I want to talk about this a little bit more, but addressing your negotiated rate, like the lesser charges or percentage charges, reality. I think you can get around that several different ways. We can talk about that several different ways without actually saying that you want to do that and open your contract back up for negotiation. So we're going to walk through that, but it all starts with the phone. Jurisdictions. I always like to tell everybody a lot of these jurisdictions and these contracts like WPS, they've had their contracts since the 60s and 70s. Since the war on poverty, some of these administrators have been in place with nearly identical jurisdictions. So I always like to tell people they grew with the health center movement. So they do understand you on the Medicare side. I think sometimes people think that Medicare can be, or CMS can be awfully rigid in their thought processes, but I also we've been with them the longest. Don't forget that when you're trying to engage them. Facility enrollments, they have primarily 5 factors. So without pulling down the contract, we'll go through here in a minute. You have your 10, your NPI, your provider transaction access number by site, which is the favorite number for our credentialing team here. I'm kidding, it's not. License number as applicable, that's primarily related to pharmacy, or if you have a CLIA, wave lab, that you need to identify, and your drug numbers, your GEA numbers. And so almost every base facility enrollment includes those 5 identifiers. By the time you fill out that enrollment, better have it in place. Once you have those in place, you're going to tie those individual entities or those individual providers to it. Prevention rules come into play, but it's often dependent on state law. So the provider enrollments for me, I have to pay really close attention on two things because there's two really big inconsistencies states we're in, and that's optometry and dentistry. And, and so I would pay attention to those service delivery specific services when you're looking at that. Kansas deals with dentistry drastically different than the state of Oklahoma. And so, best example I could tell you is that I can enroll Kansas dental in other states or dental clinics in other states or allow them to seek reimbursement, but state of Oklahoma establishing a dental clinic down there and getting reimbursed is a completely different ballgame. And so very strict dental for the state of Oklahoma, similar to optometry, where optometry drastically different states. To the point at which, again, I'm almost completely separate from us. Similar things here are important. You know, we're looking at those 6 identifiers. A license type, of course, is most prominent. Something I always like to tell people is pay attention to what becomes a licensed independent practitioner in that particular scenario. So, APRN is more prevalent in both the state of Kansas and the state of Oklahoma as they've moved into practice status over the last couple of years. Active category of that license can affect reimbursement. So pay attention to that, along with they might want to know, again, back to dental sedation-based numbers. So what level sedation permit? MPIs, of course, the same provider transaction access numbers, license numbers, of course, and PA numbers, again, for prescribing relevance of those. Okay, kind of get into the juice of it here. Talk about some contracting pitfalls. I didn't provide a specific contract today. There are many contracts that have similar provisions. I just kind of want to walk through them generally. If we do a 2.0 of this, we could certainly look at a specific contract. The network did a great job of giving me an example, and it kind of mirrored what I was looking at already. And so we're gonna kind of just address that. Most contracting fees are established around your charge master. Don't ever forget that. And then, I often, when I'm talking to a vendor or an insured company, my number one lead is that your contract on paper doesn't necessarily address the complexity of the organization or the complex nature of what the service we're delivering. And so we try, we review our contracts regularly, but we also try to have active communication and dialogue with insurers or insurance companies like you all do. So our iteration is at least once annually. We're having a conversation with these insurance companies, and a good chunk of them we meet in person. And those meetings are outside of ongoing communication that already exists between our credentialing and contracting department, our revenue cycle team, that insurance company. So, but really, we're doing our best to make sure that we talk to them actively. I think one of the more readily factors in this is evergreen contracts. I strongly discourage evergreen contracts. If you read all of our federal procurement rules, the federal government as it relates to being FQHC really discourages those type of long-term evergreen relationships, regardless of whether you pay them the federal funds or not. They just think it's bad business. We're going to talk a little bit more in depth about this in a minute, but indemnification provisions are often not mutual, and they're often vague, and that's a way you certainly can talk to insurance companies about these contracts. And continual issue of being on par. And so, what I have found more recently is that, um, we might be labeled as non-par for an insurance company that did nothing wrong. And they are notifying their beneficiaries and their customers that we're non-par when in fact it's not accurate. And that we've used that as leverage to, to have those subsequent conversations and do this dialogue about these contracts with payers. And at times we've even had patients bring in those letters that they received. And stand the go chart send them our way. We'll discuss those with insurance companies. So, not saying that is a pure pitfall. It's a pitfall that leads to an opportunity. So, something to think about. Lack of retroactive enrollments, despite submitting everything timely. I haven't found an insurance portal I like, to be honest with you. They all have flaws. I think they're similar in certain instances to EMRs, where we all wish it was a little bit better or a little bit different. And so, constantly battling those portals, whether it be from an insurance enrollment perspective or a prior authorization perspective. We're doing both. And just always fighting on those things. And I again, back to those discussions with those insurance companies, I fundamentally believe that you can't tell them enough about how consistently health centers have the best medical loss ratios for any insurance company, and relevant to anybody they're enrolled with. And that is certainly something you should lead with. But they uniformly have a lack of understanding, and sometimes, given their definitions, whether that be safety net provider or grouping us with health hospitals in Kansas, believe that at certain instances that we are more costly than we are. Certainly a lot less costly, both high quality and low cost, and to ensure that every opportunity to have that discussion and work on it. This is another slide I like to illustrate. This one doesn't get as updated as much as I'd like, but I often I use this to better understand the markets that we live in. Blues are growing across the country, and United is continually growing across the country. It's interesting. I was studying this the other day versus just better understanding of ACO groups and where ACOs are based out of. And it actually provided me a little bit more clarity as we related to ACOs that were based in certain metropolitan markets and their relationships with some of those insurance companies. So whether they be good or bad or different. So, but this is, this from a commercial side, this is who we have to deal with. So knowing these pitfalls, the common question is now what do I look for? What do you look for? So I will tell you that there's probably at any given time, there's half a dozen insurance products, sitting on my desk or in my Microsoft Planner, ready or my email ready for me to review, or re-review. So I try to address it from a trends perspective. That's what we're going to talk about. So, two common topics is network versus direct enrollment. We're going to talk about some of the benefits and detriments of both, a strategy related to what you should do or could do. And then we're going to talk about provisions to review, regardless of the type of enrollment, whether it's a network or direct payer contractor, which is what I've done. So common question that we're always talking about internally is a network enrollment better than a direct payer entity enrollment, or vice versa? And how do you really know? You know, at the end of the day, you're going to enter into this agreement. Claims aren't going to hit for, you know, you're not going to get paid. Claims aren't going to hit for a number of months, and then it's going to take time to trend it. So how do you really know if this is beneficial to your organization, to your patients? Network enrollment, you know, these are some things that you guys may look at or not. You know, I look at network enrollment and I look at, does it have a roster base enrollment and is it retroactive? Meaning I execute the base network agreement. I have a certain period of time of which I have to update that, whether that be within 30 days of change or every month or 6 months, whatever the iteration is. Does that retro back to the date of which that facility changed or that provider started or whatnot? And so, generally speaking, I love, and you guys I'm sure do too, I love roster-based enrollments. You know, let me load that MPI, let me load the unique identifiers and move. It reduces RAR, and it creates efficiencies. I'm looking at roster-based enrollment from both the network relationship. I'm looking at it both from the facility and provider side. So if I'm going to add a facility, what does that look like? If I'm going to add a provider, what does that look like? Roster network-based enrollments typically don't address services as well. I found that out. It's more of an all or none thing on your enrollment side, but it's a little bit different on their side as it relates to product lines. But on our side, it doesn't. And typically, as it relates to commercial contracts, I see a better reimbursement rate in network enrollments, and I'm comparing those rates. So I'm taking, you know, I'm taking that exhibit from that network enrollment, and I'm literally lining it up with a direct payer contract that payer might have sent me, independent of my asking or me asking, and I'm comparing the two. And I would say 8 times out of 10, the percentage of charges, particularly on commercial contracts, is better. That changes a little bit with some of the massive commercial plans, but most of the time that's accurate. What's the detriments? I don't know about you guys, but I do like your ability to make your decision on behalf of your organization, and you do lose a little bit of autonomy in network-based enrollments. They typically, you know, similar to like accountable care organizations or buying groups, you know, PSAOs in the pharmacy world. There's a little bit less autonomy as it creates a scenario where you aren't involved in rate setting, you're not involved in negotiation or renegotiation of certain issues. Timely filing requirements is my aim, number one. You know, most of the time, you don't have the ability to affect what a timely filing requirement is in a network contract. There are, you know, the catches. You know, I think the unique thing with network-based enrollments is that you do catch certain plans that you don't regularly see, but it does create some other issues where they don't know your practice and you don't necessarily know theirs. We've seen that a lot on workplace health plans. The network enrollment at the same time has created, I think, certain benefits for us as it relates to our practice at Pittsburgh State University. But it does create those weird, unique scenarios, which I think is more, you know, it's good that you're catching the plan, but it does make it a little bit, I'll not explain it, nuanced in how you address it. So I just have a lot of workplace health, and I think we will for a long time. Scenarios where I'm working through, you know, our revenue cycles, identifying a workplace health plan that are enrolled in and should have been paid for underneath the network, correcting that trend, and then we're having to go back to that plan specifically through the network and renegotiate. Just creates different scenarios. Network enrollment and breaking down lines of business. Um, the interesting thing with networks is they frequently break down lines of business with the intention of getting the best deal. And so, they're going to break out each service type, with the hope that they're going to get the best deal by service type. That's great most of the time, but similar to what I was talking about with workplace health, I've had two scenarios in like the last week where we're enrolled in the network, we're par with the network, we're par with that specific payer, but we're not enrolled in all lines of business, because the network and the payer are negotiating specific line. And so we don't get paid on that. And then it identifies us for non-par, even though the network's negotiating that with the payer. That's, again, one of those gives and takes. You have to be okay that that happens, or at least know that that is an existing reality or a likelihood. And so something I live with. Payers, often include those lines of business underneath the base contract. The direct payer enrollment is a little bit more encapsulating in that sense that you get commercial Medicare, MCO, Medicaid MCO, and then Medicare and Medicare MA. Again, this is a little bit more on the direct payer. We have the ability to add those. These are our examples on our direct contracts. Our United plan includes a base contract for commercial, Kansas Medicaid CHIP, Medicare Advantage. Then we added in actually at United's request because we were seeing so much Missouri Medicaid from two communities in Missouri that were coming to three of our clinics in Kansas. We added in Missouri Medicaid last year and were able to better negotiate that rate. And then Oklahoma Complete is our base contract with them, really centered around Oklahoma Medicaid, commercial, and Medicare. Oklahoma was, one of the more recent states that did the expansion of Medicaid, and they're, underneath the previous administration and this administration continue to evolve their Medicaid contracting program, and so getting that in place was a trip. It took about 18 months to successfully get that done with Oklahoma Medicaid, and that was but they've had a lot of hurdles at the state level, ensuring that's timely in place. So those are our examples of our base contracts and what I call direct payer contracts that we hold. We hold many more, but these are two ones that were top of mind due to recent tasks I needed to accomplish. So again, back to the original question, what is a good or better practice? Network enrollment, direct payer contract, or both? This is my opinion, based off of my time and experience, is, we keep meltable network enrollments with the hope that we catch several individual insurance payers captured in that enrollment. Going back to the workplace health stuff, we want to catch some of those payers that we otherwise wouldn't know exist, or that Pittsburgh State University scenario, or some Missouri specific payers, Arkansas specific payers, Oklahoma specific payers list. So use those network enrollments to help us accomplish that, and actually collaborate with large hospital systems on sometimes how their network enrollments work, because really they want us to participate in those networks. We're consistently reviewing these. Again, at least every 6 months, I'm reviewing provider manuals to ensure, do we have a duplication issue, or not, and then I'm addressing non-par inconsistencies and within that base enrollment. So I'm keeping a couple network contracts at all times, but I think that's the best practice for us. I'm also keeping the provider-based contracts with the top 5 to 10 insurance payers. I'm running that by clinic. So those reports I'm talking about, our credentialing and contracting team, along with our revenue cycle team, consistently run reports. We do it by provider, by site, and by payer. Then we're analyzing that to determine what contracting opportunities we have. A lot of that goes to the last bullet, is how much time you want to spend in analyzing this from the FTE perspective, and how much staff do you want to have that chase this. Something that we have consistently reminded ourselves of is the fact that high functioning, good credentialing and contracting staff, along with good revenue cycle staff, are revenue generating staff. You know, you can never forget that, that every time they catch something or they do something efficient, they reduce your AR. They create, better patient satisfaction in the sense that you have patients that are consistently dealing with issues on their side. So, but that's something I'm constantly analyzing as it relates to FTEs that are underneath my purview. Common false fears. If there's an overlap between the network and direct contract, that's a reason for non-payments, non-par, confusion. People often say, well, there's going to be confusion between the network, the insurance company, and your health center. I disagree with that. Common reality is non-payment is on an individual claim basis. We didn't drop the right code. I think often the common reality is that this scenario helps us identify specific contracting issues. Do I need to move away from a network enrollment to a direct payer contract for a specific payer? Again, if I'm paying attention to those scenarios and knowing when I need to pivot because some payer has made it into one of our larger classification payers. And then, believe it or not, provider manuals can be intentionally vague. So take advantage of it. We're going to talk about that here in a minute, but don't forget that you can take as much advantage of it as they can. Common reality, those direct payer contracts often illustrate value. Again, going back to those specific provider ratios, and can lead to better opportunities for value-based care add-ons. I've consistently found that direct payer contracts lead to a better analysis, understanding on the payer side of things like medical loss ratio, which leads to payers asking us to do things that show that their customer base is actually costing them less money. And so that they talk through attestations and incentives and PMs. So those are ever existing discussions. But those discussions only exist in those direct payer contracts. Very rarely do they exist in a network agreement. Actually, off the top of my head, I can't think of one instance where we've had a network enrollment that has led to a value-based care. And so you just got to know that going in. Thoughts that lead into that always, again, goes to contracting. How's your health center? Is your health center set up for value-based care in the future? We historically health centers have historically been better set up to this in an ACO because that our preventative care mindset, the idea that we're trying to avoid costly care, and it helps us align well. And you at all times you just got to keep reminding yourself you have to illustrate value. That's hard to do when you're grouped with non-like-minded entities, which is why I do both direct contracts for the large payers and network agreements. I'm capturing some of that. Common question, as we get closer to 2030, are you capturing more of your insurance enrollments in value-based agreements? Meaning, are you, as a percentage, not only getting paid for the service delivery in the exam room, but do you have a bigger lump in value-based care over time, by 2030, we all know that you have to participate at a great clip on the federal guidance. And so, I'm paying attention to that as I'm going through insurance contracts to make sure that at least both insurance company and us are both knowledgeable. So regardless of all that, what are key provisions to review? What are things I'm wanting to challenge? These are the things that are always top of mind. Again, you guys will have these slides, so review them and do with them as you choose. I look at definitions pretty uniformly. I always go straight to compliance and malpractice insurance. Talk about that. Representation and warranties, hold harmless provisions, and then term and termination. Those are my big five. So in any insurance contract, I'm really going there first, and I'm working my way through other pieces, because as we've talked about, those other pieces will allow for the opportunity to talk about negotiations. Do you have a baseline understanding of those important definitions? Knowing that some will overlap from contract to contract. Again, insurance companies aren't overly sophisticated on that particular thing because they're either looking at something CMS published or a state published, and they're not going to go too far away from definitions. Knowing that at the end of the day, arbitration clauses might not be enforceable if they dip away from these definitions. So I'm looking at insurance company. The actual name sounds ridiculous in the preamble, and then I'm looking at payer. So one of the biggest misconceptions is that the insurance company and the payer at all times are defined the same in an insurance contract. That is not true. Payer can be a fully owned entity of the insurance company that has unique responsibilities underneath the contract you entered into with the insurance company. Most common example is United with Optum. Optum is often a payer under a contract, but they are not necessarily the insurance company. There's many other examples that we go through with regards to Centene or Sunflower or Blue Cross. But just keep in mind, payer again is another who is often in insurance contracts limited to the insurance company, meaning that they're only associated with the insurance company versus a subcontractor. How do they define subcontractor? Subcontractors can often apply to both entities. This is on a following slide, but a subcontractor could be someone that does something for us, depending on how your health center is set up. And a subcontractor needs to be held responsible or would be held responsible for the same provisions as the insurance contract. So it's important to keep in mind that the insurance company, the payer, and the subcontractor all might be different entities underneath your insurance contract with unique responsibilities that not necessarily have the ability to seek recourse. So a payer often maintains an obligation or agreement that does not necessarily confer back to the insurance company. And then dependent on the service rendered, the payer, not the insurance company, might be obligated to perform with no recourse against the insurance company. And me including, I've seen in several insurance contracts that a payer may perform something on behalf of the insurance company, but you cannot seek recourse against the insurance company or the insurance company for delegating that responsibility to the payer. That's an easy one to talk with an insurance company about, because there should be common alignment and responsibilities between an insurance company and the payer in your definition. And so that's not a hard one to ask for. And again, if it doesn't exist in a contract and you've already executed, it's likely challengeable anyways due to common ownership amongst insurance companies, insurance products. Basically, I'm saying it's ridiculous to think that those two things wouldn't align from practice. Important definitions stay in there. Protocols, customer benefits, and payment policies. protocols are to be followed when delivering services. More protocols are including PA responsibilities, something I've noticed a lot of. Customer benefit plans, more aligning covered versus non-covered services, and then payment policies illustrate the nuances often related to protocols and customer benefit plans. Payment policies, number one, are doing time of filing. So are you studying those three things? Are you understanding exactly what they say? And understanding it from it? When I'm looking at this, you have to understand that most states require updated customer benefit plans and associated protocols and policies when they do their own updates. Commonly via rate setting letters or updates to state plans. So I'm always looking to see when those things in the contract are supposed to be done. If you catch it first, do they do something different? It's done a little bit more through my staff now than me, but we're always asking for these updates and we're always communicating about these updates, both with those stakeholders and internally. But we're asking for these documents. Functionally, we're asking. Compliance and malpractice, to jump there, you often have a requirement to comply with jurisdictional requirements, contract law in the state of Kansas, while an arbitration provision would exist in the contract. I would always tell you, and most of these contracts include it, it's hidden at the bottom of the arbitration dispute provisions, is that most of these provisions challenge a state court, particularly if you believe that the insurance company's acting in bad faith. Again, these insurance companies, most of the big ones have entered into agreements with the state, and then they're having you enter into direct contracts that include that state product. So you're going to be able to challenge it if you don't believe they're following state guidance. And so I would tell you, don't be necessarily scared if you think you need to go that far about an arbitration. Or at least you can definitely ask them. Malpractice insurance, a little bit of a quirk on our side is, they often state specific requirements for both the entity and the professionals. I would tell you this, to be careful about how your health center delivers services as it relates to column 1, column 2, and column 3 filings on Form 5A. I'd also tell you to be careful as it relates to FTCA compliance manual guidance and determine, does the insurance malpractice insurance requirement that's in that contract, is your professional covered underneath that, depending on a specific service and the way it delivered? Are they covered by FTCA or not? Are they covered by your gap insurance or not? I would just tell you to be diligent in that, because often the malpractice insurance requirement, the fault of the insurance company is that they believe everybody is covered by FTCA under all scenarios, and we all know that's not true. But I would just tell you, at least for your own education, to continually review that. Sure you haven't missed anything. This also allows you an opportunity to discuss how a health center works from a malpractice insurance perspective if you think necessary. Again, a friendly way of opening a contract up for discussion or negotiation is if there's changes on that provision, because you got to open the contract up anyway. Again, and those changes might be forced on us in the way of pitfalls, but it does allow a unique opportunity to go back to the table and talk about the whole thing. Representations and warranties, often exclude or extend extensive requirements for the facility and the professionals, again, on us, relating to good standing, requisite corporate power and authority, similar provisions. The one thing I would mention here is that, is there good debarment language for for them? Does it specifically state that if they were debarred or they're prohibited from entering into certain negotiations? Was that represented as an expectation for them in those contracts? It's a reasonable expectation that they be there if they're not. So keep that in mind. I know I'm running a little bit short on time, so I'm gonna end here pretty quickly, but hold harmless provisions. Um, be careful with how that reads. Uh, uh, hold harmless in substantive agreements, attachments often isn't uniform, when it should be. Again, similar to indemnification provisions. So pay attention to that. At all times, it should be mutual. And the one piece I would tell you that insurance contracts seem to have forgot is that they don't specifically address cybersecurity topics. They're high-tech expectations that are on insurance companies that date back to 2009 still aren't in insurance agreements. And so that is something that you are allowed the opportunity to specifically mention is that they have cybersecurity expectations that they should have as it relates to their customers and how they interact with you. And so that's not in there. It's certainly something you need to talk about, make sure it's addressed somehow, somewhere. And then term and termination. Again, I don't like anything beyond 2 or 3 years, but I always want an opportunity to term without cause. That's pretty much a non-negotiable for me. That's not at all times. Then, I'm looking at this. Does the term allow for updated fee schedules? And how does that look? Fees should be regularly reviewed and term provisions open that discussion. So, again, I'm using the term and I'm leveraging that as an opportunity to talk about my reimbursement for FQHC and non-FQHC visits. And that might come from a revenue cycle side. They might say, our charges look off here. What does the term look like? And talk about it. Then my last 2 slides, and these are just more things that I pose to you and always keep top of mind. Who's responsible for reviewing and keeping track of state, federal, and payer specific updates? Do they compare those updates against your existing contracts for consistencies? An opportunity to discuss with the insurance company. So, what does that look like for you? It can involve an assortment of staff with different responsibilities to research and collaborate. And I would encourage you not to be siloed in that thinking. To at least have 2 or 3 different staff members from different parts of the organization and have a little bit of overlapping responsibilities, so that you can go at it with different angles. Look at it with different sets of eyes and silent processes. So I know, Christy, I ran long. I think that was my last slide. So I apologize to anybody that has any questions. Happy to answer them.
If you have any questions, you can definitely put them in the chat, or you can come off mute to ask anything. Well, it doesn't seem like we have any questions. Know that if you have any questions for Daniel after this webinar, definitely forward those questions to us, Christy or me. We can forward them to Daniel through email, and we can have him answer them that way. We definitely thank you today, Daniel, for all of your information. I have learned things. I hope everybody else has learned things on this webinar. And I'm sure I might have questions after the fact. So we definitely thank you for all your knowledge. There is in the chat our link to the survey we ask that you click on that link and let us know how it was and if there's anything in the future that we can help you with, or we can have other webinars on subjects. We will send the recording out to all of you after this is over. It might be towards the end of the week, but we will definitely have that recording up for you. I think that's it. We very much appreciate everybody's time today. And everybody have a great and wonderful Wednesday and the rest of your week.
Thank you all.